So now let's talk about benign enlargement of the prostate. There are different names which has been used, BPH, BPE, and now this is my presentation for today, and we'll be talking about the BPH right now. I'm presenting a clinical scenario. This is about a 62-year-old man who presented in a clinic with difficulty in urination, dysuria, hesitancy, and feeling of incomplete emptying of the urinary bladder, and nocturia for last 6 months. On physical examination, his abdomen was tender in the suprapubic region. And on digital rectal examination, his prostate was found firm in consistency and there was an enlarged prostate. Now this patient was referred to a urology service for further management. Now let's dissect this case, that what is happening and what is this clinical condition. This history takes us to which part? If we dissect this clinical case, it tells us there is a problem. This old man has difficulty in urination. But when we do the rectal examination, the gland is firm in consistency. It's not hard. It's not soft. First, let's understand how we can differentiate between hard, firm, and soft. A very easy example of understanding firm. What is firm? If you touch the tip of your nose, this is something which is called firm. Hard, touch your forehead or the top of your table, that is hard. And soft, touch the lobule of your ear, this is soft and tender. So these three are the consistencies, different consistencies of the prostate gland. If the prostate gland on rectal examination, it gives you a hard consistency, you should start thinking about the cancer of the prostate. If it is firm and enlarged, then the suspicion of benign enlargement of prostate should come in your mind. And if it is soft and tender to touch, then we are dealing with a case of prostatitis. When we talk about BPH, primarily patients are presenting with some kind of clinical manifestation. And nowadays, the urologists, they love to call these symptoms as lower urinary tract symptoms. In early days, this was called prostatism. Now this word prostatism has been replaced by lower urinary tract symptoms. But remember, lower urinary tract symptoms, they are not necessarily because of the enlarged prostate. So there are so many other contributing factors. So let's look at what are those different clinical conditions which results in lower urinary tract symptoms. So number one is my benign prostatic obstruction. Then we have overactive bladder, nocturnal polyuria, foreign body sensations, urinary tract infection, distal ureteric calculi, bladder tumor, neurogenic bladder, underactive bladder, urethral stricture, chronic pelvic pain syndrome, and there are other things. So all these conditions, they may present with lower urinary tract symptoms. So how we can differentiate? Today we'll be talking about benign enlargement of the prostate. So let's look in that. But before going into that, the lower urinary tract symptoms, they are primarily divided into two categories: voiding symptoms and storage symptoms. The voiding symptoms are weak stream, prolonged voiding, abdominal straining, hesitancy, intermittency, incomplete bladder emptying, terminal and post-void dribbling. And the storage symptoms can be frequency, nocturia, urgency, urge incontinence. So all these are different presentation of my lower urinary tract symptoms. Now we are looking into this image which is showing the involvement of the transitional zone, and that will result into bladder outflow obstruction. If you look at the bladder neck, and the pre-prostatic urethra part. We can see this is not a normal appearance of the prostatic urethra. This is quite narrowed and this area is being distorted. To understand this, that what are the different events which are happening, and due to these events, what are the different clinical presentations are coming. So let's explore inside. Now let's zoom in, and now what we can see here, due to the involvement of the transitional zone, part of the transitional zone has been protruded inwards into the lumen of the urinary bladder, and that has created a ball valve like appearance. So this protrusion inwards, this is the transitional zone of the prostate, and it has protruded into the bladder, and it has distorted the internal urethral sphincter. And we can see that these are the location, and this internal sphincter has been distorted. And due to this distortion, it will result in what? Incompetence. Now, this sphincter is not performing the way it used to be performed, and there will be loss of control. As a result of that, the dribbling of the urine in the prostatic urethra will become a regular feature. After that, when we look into the prostatic urethra, what is happening here? This is also being distorted, and that will result into progressive obstruction of the urinary outflow. So bladder has to exert more and more and more, and that will result into the hypertrophy of the bladder wall. This is, we are looking at the ureteric orifice. Now the urine which is coming up, bladder is unable to empty itself because of this ball valve effect, and urine stays here, and this gives a feeling of incomplete voiding. So this collection of the residual urine in this reservoir, which has been created due to this transitional zone, and that will result into patient will have an urge to pass urine. There will be frequency, urgency, and patient has to wake up multiple times in the night because the feeling of having urine in the urinary bladder will be a constant feature due to this residual urine. And in the last, what happens? Dribbling of the urine is a regular feature into the prostatic urethra, which is quite sensitive. And why this is happening? This is due to the incompetency of the sphincter, and that will result what? The symptoms of irritation of urethra, and that will lead to the urgency. So these different anatomical changes will result into clinical manifestation of lower urinary tract symptoms. Now if you look into this section, you can see that due to this enlargement of my transitional zone, look at the urethra which has been almost clasped, and due to that bladder has to exert extra, and that will result into all these kind of problems. Who's suffering from bladder outflow obstruction, that includes a detailed history and a physical examination. And physical examination should include digital rectal examination, and this digital rectal examination is one of the keystone, and this will tell us about that are we dealing with the benign enlargement of the prostate, or we are handling with a prostatic cancer, or we are dealing with a prostatitis. So the workup includes, first we have to gather these symptoms, and we should look for the quality of the life. So there is a scoring system, and we do that. Then we need to look into the urine analysis. It gives us a lot of information. Then we should look into the function of the kidney, that what is happening due to this bladder outflow obstruction. After that, if we can find any nodularity or any area of suspicion on the digital rectal examination, we may subject our patient for prostatic specific antigen, PSA. If it's needed, we have to perform this test. And then Ultrasound KUB with pre and post void residual urine is a very important non-invasive investigation, and it gives us a lot of clues. After doing that, uroflowmetry, another investigation which gives us so many patterns, and last but not the least, the flexible cystoscopy, which is done under local anesthesia, can give you a full insight of this bladder outflow obstruction. On the basis of these investigations, we may divide the bladder outflow obstruction into mild, moderate, or a severe disease. For a mild disease, usually we follow the conservative approach. In conservative approach, what we do a watchful waiting. What we do in the watchful waiting, we ask the patient avoid taking fluids before going to bed, and especially not consuming alcohol and caffeine products before going to bed, and then should be utilizing some bladder retrainings and continence products which can be helpful in the mild symptoms. If the patient present with the moderate symptoms, there we need to use certain medication, and this medication includes the alpha blockers, 5-alpha reductase inhibitors, and the combination therapies, and last but not the least is the phytotherapy. What is this phytotherapy? Phytotherapy is usage of different naturally occurring herbs and different plant products, and they are useful, but a lot of data is required for reaching to a conclusion. And for the severe disease, definitely we need to do some surgical management, and the surgical management is divided further into minimally invasive and invasive procedures. The minimally invasive procedures are more designed for a small prostate, and the invasive procedures are for the bigger prostate and the prostate with more symptoms, specifically when we have acute urinary retention and situation like these. Remember, nowadays doing open prostatectomies is very low. The incidence of doing open prostatectomy is very reduced. The most preferred method of doing surgical procedure on prostate is through transurethral resections, and for this transurethral resection we may use different modalities. It could be a laser or other procedures. Thank you very much.